We're going to go ahead and get started. I wanted to welcome everyone to the webinar this evening. I am your host and moderator, Dr. Lauren Levine. We had another great turnout as always. We have close to 900 people registered. For those of you who know my voice, this is not me trying to do my Elizabeth Holmes impersonation. I'm a little under the weather, but we're here and we're going to have a good time. I hope that everyone is staying healthy and safe out there. As always, kudos for showing up. These courses I think are great for continuing dental education. We all got to do it, so why not do it when it's free? And we got great speakers like we do this evening. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Kosinski can speak for as long as he needs. We also want to take questions at the end. Most of you have been on these webinars in the past, so you know how it works. On your screen, you have a GoToWebinar control panel. You type in your questions as you think about them. I don't normally get to the questions until the end. With every webinar, it's different. I don't know if we're going to have 5 questions or 105 questions. I'm the only one that can see the questions. I'll try to consolidate some if we have a lot. I'll try to get to as many as we can. But if for some reason we don't get to your question, I apologize. The questions get sent to to Golden Dental. They will, be able to follow up as well. Speaking of Golden Dental, during the webinar, Dr. Kosinski is going to be demonstrating a few products and systems that he uses, which are exclusive to Golden Dent. I cannot do these webinars without their ongoing sponsorship. We've been working together for years on this. If you're in dentistry, you know who they are. You know that they're committed to dental education. Speaking of Golden Dent, after every webinar, I usually get a dozen emails or so asking about the CE. I'm going to try to mention it at least 3 times this evening. The CE is given to people who attend and stay for the bulk of the webinar. As long as you're on the webinar, you will be sent a CE form. You don't have to take a quiz or, register or anything like that. Obviously, if you only pop on for 5 minutes, you're not going to be sent a CE form, but it's rare that people would try to do that. So it can take a couple of weeks for them to get those forms out when we have this many people. So please be patient, check your inbox. If in a week or 2 you don't have it, by all means, shoot me an email and I'll follow up with them to make sure that, sometimes it goes into your spam or your junk folder, so you should check that as well. So with that out of the way, I wanted to welcome back once again Dr. Tim Kosinski. He got his DDS from the University of Detroit Mercy Dental School. He got a mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the ABOI and implant dentistry, the ICOI, which is International Congress of Oral Implantologists, the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry. He got his mastership in the Academy of General Dentistry. He's also an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He's on the editorial review board of Reality, which is, most of you read that. It's the information source for aesthetic dentistry. He's the past editor of the Michigan Academy of General Dentistry. He's currently the associate editor of the AGD journals, and he was honored to have been named editor of Implants Today, which is the implant publication of Dentistry Today. He's also past president of the Michigan Academy of General Dentistry. I think we're out of time, Tim. I don't think we have time for your presentation. I had to read through all that stuff. So, Tim, take it away. We're thrilled to have you on.
All right, Lauren. I hope you feel better too. So
thank you. I'll be monitoring. Don't worry. I'm not going anywhere.
But the good news is you're in California and we're at 18 degrees here in Detroit. So
yeah, we're about 18 Celsius here actually right now. So a little chilly.
Okay, smarty. So thank you, Lauren, for having me again, and thank you to Kurt at Golden Dent for sponsoring me. We had given a program similar to this about a year ago during COVID on suturing techniques, which is kind of an odd topic. But we've been asked several times to repeat it or to update it a little bit, and so I've been back on the road a lot, and we've been our courses have been pretty full, and suturing is such an important part of what we do. Most of you have heard me, or many of you have heard me talk about atraumatic extractions and our atraumatic extraction techniques using some of the Golden Dent tools. Atraumatic meaning we are maintaining the available bone as much as possible, making our extractions as simple and minimally invasive towards our patients as possible, but also saving our bodies. And going along with, Lauren, going along with extractions is our preparation for dental implants, which we do a lot of dental implants. It's an important part of our practice, and should become an important part of most general practices out there. So to prepare sites for implants, we are going to demonstrate some of the grafting techniques we use. And going along with extractions and grafting and implants is suturing. So we'll take some time in the next hour to just discuss some of the most important suturing techniques that I use in my practice every day to ensure that you get, number one, bone growth, and number two, good healing of your dental implants and fabrication of nice fitting crowns with form and function, and just quality of work that you're going to be able to provide your patients. I'm in private practice in Bingham Farms, Michigan, outside of Detroit. And as Lauren mentioned, I'm an affiliate adjunct professor at my dental school. A lot of the things that you're going to see here today are on my education website. It's simply an education website with many of my articles and videos and YouTube videos and demonstrations of the techniques that we'll show you today. So it is a good resource if you're so inclined to follow up. So what we want to do today, our goals are to learn some of the predictable suturing techniques that will allow you to get predictable healing results. We're going to talk about flap design or reflection design to maximize your aesthetics and healing around bone grafting and dental implants. And we'll briefly give an overview of the different types of sutures and needles that we use, and why we use the different materials and different applications. And we'll talk about the knots, how to get proper suture knots so that things don't come loose, and so that you can follow up with the patients with proven results. And then we're going to obviously, to talk about suturing, we have to talk about some of the extraction and grafting techniques that we use in preparation for dental implants. So again, this is not going to be an implant training program, but it's important that we understand that suturing is a very, very important part of what we do in our surgical applications. And in this 4-slide little description here, we have an edentulous space where we reflected the tissue, and you can see my reflection is very specific here. I'm going to refer to this as an envelope reflection. An envelope reflection meaning, picture a number 10 envelope, the long envelope, and you lift the flap and you blow into it. So it allows me to have a lot of control with my reflection of tissue to expose the available hard tissue and the site for our dental implant. The type of implant is really irrelevant in our discussion today, as will be the techniques of placing implants. But here we have an end osseous implant that we prepared a site, and we're threading it into the hard tissue in an ideal position, trying to think about shape of the tooth. We're not so much thinking of implant placement, because we're simply placing a screw in bone. Rather than we're thinking of tooth position and control of the soft tissue. You can see in the upper right column that I did not make any vertical incisions, which allows me to replace that reflection passively back into place, so that we can eventually get good healing in that site. So eliminating the vertical incision into mucosal tissue allows me to control the flap, but also eliminates the discomfort that the patients may exhibit when you do incise into mucosa. We know that if you make an incision into mucosa, we will get prostaglandin and histamine release, and the patient will experience a lot of discomfort. The reflection that I'm making here, where we're simply going around the tooth and doing that envelope reflection, so to speak, allows me again to replace that flap passively over our surgical site, and allows me to suture it quite readily. It also eliminates a lot of the postoperative discomfort that your patients may experience. So when I have a reflection as we just described, I'm able to suture the site. And here what I did was I did what we call a mattress suture, a vertical mattress suture, which is a nice, simple, easy suture to place to replace that tissue where it was initially excised from. The important aspect here is that we have a band of attached gingiva on the facial aspect of all my dental implants. And this is imperative for your success of your dental implants. Lauren, being a periodontist, you can appreciate this. So it's very, very important that we install at least a 2-millimeter band of attached gingiva on the facial aspect of our surgical sites. And this is going to create periodontal health in a very strong emergence profile with smile design. And I'm going to demonstrate how I actually did this with some video demonstrations. Tissue repositioning is going to be an important part of my program today. Many of you are aware that place dental implants, that if we're able to torque our implants to a certain Newton centimeters, meaning the literature will say if we can torque our implants to 25 Newton centimeters of torque, gaining initial stability, we can actually do what we call a one-stage procedure. And that means that I can put a healing abutment. A healing abutment is simply a taller screw that penetrates through the soft tissue that eliminates the need for future uncovering of the implant, which eliminates the need for anesthesia. So basically, I can congratulate the patient and say, hey, your bone quality was so good, we were able to do 2 surgeries in one. The patients will say, what do you mean? Well, no more shots after today. But as I just mentioned earlier, it's important that we reposition our tissue so that we have a clear band of attached gingiva of at least 2 millimeters on the facial aspect of our implant. Many of us, when we suture a site from facial to palatal or lingual. And that's fine in some situations, but in other situations it's not. And in this particular series of photographs, what we did was we are making sure that there's a band of attached gingiva on the facial aspect of the implant. And again, I want to demonstrate clearly to you my suturing technique. And in the upper left photograph, you see a reverse cutting needle, 3/8 inch needle that is reverse cutting, meaning it cuts on the top surface or the coronal surface of that curvature on the needle. And what I'm going to demonstrate today is my suturing technique, where I'm going from the crestal aspect of the suture. So I'm actually going from the crestal towards the facial, and then I'm going to simply turn the needle around and go from the crestal or coronal aspect to the palatal. And these are simple interrupted sutures, which we'll demonstrate in a few moments also. And then tying the knot towards the facial, again, ensuring that I have a band of attached gingiva on the facial aspect of my dental implants. So the sutures that are available to us are primarily the PGA or polyglycolic acid synthetic absorbable braided, which absorbs or resorbs in about 28 days. This is a suture that can be purchased through Golden Dent. Depending on where you purchase these sutures, it can be relatively expensive, maybe even up to $16 per suture, which is considerable. But with the Golden Dent material, we can reduce that cost to a little under $10 a suture. So it's certainly worthwhile for you to investigate all the materials that Golden Dent has to save you some of the resources in your practice. This is my go-to suture. I like it because, number one, it resorbs to water. So we don't see a lot of inflammation in the soft tissue during the healing period. I like to see all my surgical patients in 7 days, no longer than 10 days whenever possible. I know that this suture will resorb over time, but oftentimes our patients will experience a little bit of discomfort after about 4 days of any suturing procedure. If you don't explain to the patient, if we're doing an implant procedure or a grafting procedure, the patients will do really well for 3 or 4 days, and they may call your staff and say, hey, you know, I was doing well, but something's wrong. It's starting to bother me. And what that means is that the epithelium actually wants to heal, but the sutures are preventing it and causing a little bit of discomfort. A non-resorbable suture is silk. I don't use silk that often anymore. It's non-resorbable, and it does have a tendency to accumulate bacteria and plaque, and also it must be removed or will cause inflammation. Many of you in the audience today will use a plain gut or chromic gut. I do have that in the office. It's a very inexpensive suture. I find it a little bit difficult to work with and handle. You know, we all have our favorite materials, whether it be a composite or endodontic instruments or instruments to remove teeth, but it is certainly an option. In dentistry, our needles are all referred to as reverse cutting needles. They come in threads from sizes from 3 to 6. I think in your practice you should have 3/0 and 4/0 size. I think those are the most important sizes, and I think it's important that you have a 3/8 circle and a 1/2 circle size needle. Our needle anatomy, as you can see on the right, we have the area where the suture material actually is locked into the needle itself, and where it says wire diameter there, that's basically where you want to hold your needle holder to be able to properly use the instrument, and allows it to be quite effective. So again, when you're ordering suture from Golden Dent, I would suggest you order 3/0, 4/0, 3/8 circles, and 1/2 circle. And I use the PGA, polyglycolic acid, or Vicryl suture. I like it when it's stained. We have a violet colored or purple colored, which is easy to visualize and to remove. And so we don't need a myriad of products in your practice. So here's the Golden Dent sutures. As I said, here these are reverse cutting 3/8 diameter needle, 19 millimeters, polyglycolic acid braided, and it's violet in color. These are my go-to sutures in the practice, and Kurt at the end of the program today can discuss fees and everything with you to make it very effective. I find this to be an excellent source for suturing. If you need help in your suturing techniques, because suturing is very, very important to the prognosis of your final result, whether it be removing teeth and grafting, or removing teeth, grafting, and immediate implant placement or future implant placement. And it's very diagrams that are easy to follow. I would think that you would want to practice maybe on a fruit like an orange or a grapefruit or a lemon, and I think you can become very proficient in the different products. I wouldn't go to Amazon or Barnes and Nobles to look at this book. You'll be unhappily surprised at what it's being charged for. But if you go to Salvin Dental, SALVIN, they're out of Charlotte, they have this book, and I think it's $99. So I do recommend that you have this book in your library. And these are some of the schematics of the different sutures that we use. And let's look at, excuse me, interrupted sutures and the techniques. And there's different ways of handling it. You can go from facial, excuse me, facial to lingual in the situation, and simply tie a knot. When you're tying a knot, it's important, the way you tie the knot is important so that it does not come loose. I would do 2 loops forward, 1 loop backwards, and then 2 loops again forward. So you're going forward, backwards, and forwards, or you could go forward, forward, and backwards. but you do have to reverse your tying of the knot to ensure that it doesn't come loose. So if any of you out there have sutures that are coming loose, it is a technique that you can demonstrate very easily. So an interrupted suture is a very simple procedure to use. We can do a horizontal interrupted suture. We can do vertical interrupted sutures, where we are going in one side and coming out the other, and getting an ideal closure when you are incising, extracting teeth, or simply suturing around a grafted site or an implant site. Continuous suture is my go-to, and we'll demonstrate this on a video because it's so efficient as far as time goes. And here you can see I'm taking my reverse cutting needle on the distal aspect of the tooth, or the mesial aspect of the incision line, and I'm going again from facial to palatal, and I'm tying a knot, 2 forward, 1 back, 2 forward. And then I am simply going to continue the process, and I'm actually going to go through the rabbit ears. And again, I'll demonstrate this in a few moments with a video, until you get at the end, and then you will use that rabbit ear, or the tail, as your end that you will tie the knot to. And again, it's a very effective, fast way of suturing a wider area. A horizontal mattress is an excellent suture to use, and I will use this horizontal mattress technique in establishing or reestablishing attached gingiva on the facial aspect of my healing abutments. It's simply a periodontal suture that it is quite effective in establishing attached gingiva on the facial aspect of our implants. And I'll demonstrate that visually. So let's go through some clinical cases. Here we have an edentulous site, and it's very important that we look at the band of attached gingiva on the facial aspect. And again, this is the third time I've said it. It's very important that we end up with at least 2 millimeters of a width of attached gingiva on the facial aspect of any implant. Here we're doing a guided surgery. I know, again, this is not a surgical protocol, but we kind of use CBCT analysis and virtual planning, software planning, to allow us to place our implant very precisely. In today's environment, when we're doing guided surgery, our guides are always today bone level surgical guides, meaning the guide will rest on hard tissue and not rely so much on the soft tissue, which may have some movement to it. And again, with our surgical technique, we have a series of drills: small drill, bigger drill, and we will place our drill all the way to the hub. It makes a very casual, very routine type of surgical procedure that allows us to place our implant quite effectively. And here we torque our implant in place, and if our guide was correctly made, precisely made, our implant will be positioned where we had virtually planned it. So here the implant is placed in that edentulous ridge at the crest, using the apex of our adjacent teeth as our guide. Again, I will demonstrate how I did this continuous mattress suture, but we close the area quite effectively. The little cut there on the facial is where we had stabilized the surgical guide, and you can see 2 weeks post-op, the tissue heals completely and effectively in a very short amount of time. Well, we allowed the implant to integrate in a 3-month period, and I'm just going to demonstrate something that we use. We use the guide to where is that implant? We have to uncover it. So I took an indelible marker and placed my guide back in, and there it is. And I'm going to use a tissue punch to remove the tissue. But we're making a very significant error here. In a tissue punch is simply a circular blade that will incise the tissue over the top of the implant, exposing the implant so that we can get to do the internal design of that implant and make our final impression. But you can see here, I'm actually incising into my mucogingival line area and into mucosa. And I said earlier, if you incise into mucosa, you're going to get histamine and prostaglandin release, and you're going to get a lot of bleeding, and the patient's going to be uncomfortable. So I put my impression coping in to take my conventional impression, and you can see I made a significant error here. I went ahead and took the impression, but I realized that, oh my gosh, I don't have a band of attached gingiva. So I'm reestablishing, I'm making an incision on the lingual aspect of the crest here. And I'm going to actually take the tissue that was slightly lingual to the crest, where there is a band of attached gingiva, and I'm going to peel it like an orange. And this is called an Orban knife, going around the tooth. And I'm going to peel it simply like an orange to reposition that band of attached gingiva that used to be on the lingual aspect, slightly on the lingual aspect of the crest, and I'm simply moving it to the facial aspect of my dental implant. I'm then placing a tall healing abutment. Again, a healing abutment is simply a tall screw that penetrates through the soft tissue. I'm torquing it into position, and this is my periodontal sling suture that I'm going to use to reestablish my band of attached gingiva to the facial aspect of this implant. So I'm taking my reverse cutting needle here, and I'm going through the facial to the lingual area, but I am not engaging the lingual tissue. I am not engaging the lingual tissue whatsoever. I'm going around that tall healing abutment, not engaging the lingual tissue. I'm then reversing my needle and going from the distal facial to the crestal area, again, not engaging the lingual tissue. And I'm coming back around that healing abutment and tying a knot, 2, 1, 2. So I've taken the tissue that used to be on the lingual aspect of the crest, and I've moved it to the facial aspect of my healing abutment. Now, I do have exposed bone on that crestal area. Epithelium will predictably grow 1/2 millimeter to 1 millimeter a day. I don't cover this with anything. I don't put any acrylate on there. I don't put any barrier on there. The patients do not experience a lot of discomfort, and we will allow this area to heal. And again, I like to see my patients in a week. Here the laboratory fabricated a screw retained zirconia crown. 3 weeks post-op, when I'm ready to seat, you can see that we clearly have a band of attached gingiva on the facial aspect of my implant. And we can see that we formed a beautiful gingival cuff that the open area had filled in with epithelium, and we have a healthy site for our final implant retained crown. This is a very routine procedure for us in our practice, and something that most general dentists are unaware of, but this suture is very, very important. And Lauren, I know as a periodontist, you oftentimes see patients that will present to your practice with an implant retained crown that just experience some discomfort there. It just doesn't feel right. We'll take a radiograph, we'll evaluate it. The implant looks good, the abutment looks good, the crown looks good, but yet the patient has experienced discomfort or sometimes some bleeding. And that's because we have mucosal tissue on the facial aspect of the implant, and we haven't reestablished a band of attached gingiva. So let's just do a quick video demonstration of this. Here we have 2 implants that were precisely placed. And because we're able to torque to 25 Newton centimeters, we're putting healing abutments. And we want to reposition that tissue. So you see I've gone from the facial to the coronal. I am not engaging the palatal tissue whatsoever. I've come around that healing abutment, and then I'm engaging my needle on the distal facial aspect. And again, not engaging the lingual tissue whatsoever. Not engaging the lingual tissue whatsoever. And coming back around that healing abutment. My assistant's giving me a little hand here. Coming around that healing abutment and simply looping twice, grabbing onto the tail. And you can see my suturing technique. You only pull one side of the thread of the suture itself, one side of the thread, and that way you will not tear the soft tissue. So we've taken that band of attached gingiva that was on the lingual or palatal aspect, and we've moved it to the facial. 4 months post-op, you can see we have a clear band of attached gingiva in that area. Another situation where we have an edentulous space. Again, you can see my incisions are like an envelope where we're not making vertical incisions. We place 2 dental implants. And here we're going to bury the implants and we're going to reposition that tissue where we did not make any incision into the mucosa. And we're going to do a mattress suture here. So here I've taken my needle from facial to palatal. And we have a tail. And then I will loop twice and grab the tail. And I'm only pulling one side to tie that first knot. And you can see how the tissue lays down beautifully. And then I'm going backwards and tying the knot, and then I'll go forward again. 1, 2, grab the tail, and that knot is not going to come loose. Here my team is going to cut the tail short. Now here I'm going from facial to palatal, and I'm going through the rabbit ears. Through the rabbit ears. And that tissue is going to be pulled nice and tightly. And you can see how fast this is in real time. Facial to palatal again. Through the rabbit ears. And you can see if you have a long incision line how efficient this is in repositioning that soft tissue. And through the rabbit ears. And then we'll do our final knot by going facial to palatal. But this time, I won't go through the rabbit ears. And I'm using the rabbit ears as my tail. And the same technique. Forward. And only pull one end. And you can see how easily, and backwards once, and then forward again, and cut that. Give it a good cleaning, a good press to eliminate any excessive blood that might be in that site. And you can see we have a mattress suture that is quite efficient and effective. And I will see this patient in a week to remove those sutures. You can see how the vicryl is easy to see and easy to maintain. And again, epithelium will grow 1 to 1 to half to a millimeter a day. And here's a bigger case. And again, I like to make my vertical incision in the midline area so that I have my reference point when I'm placing my dental implant. So I'm just doing one interrupted suture. And again, coming through, tying a knot 1, 2, tying a knot. And see, I'm only pulling one end. Many of us like to pull both ends, and that's where we rip our tissue or we don't get good closure. Backwards 1. And if you follow this technique, this recipe, so to speak, your sutures will not come loose. And you can see with the Golden Dent violet colored or purple colored suture, it's easy to see. And it's a simple interrupted. And we'll do a second one there. Very quickly, in real time. And we'll snip. And now we will do our mattress suture. So from facial, trying to really watch that tissue so that we can have some semblance of closure in that area without affecting the tongue. We'll do half at a time. Again, 2 forward. And I'm only pulling one end. See how nice that closes? It's almost instantaneous, doctors. 1 backwards, 2 forward, and we'll cut the tail. And again, facial to lingual through the rabbit ears, and all of a sudden everything just closes quickly and easily in real time. Through the rabbit ears, and I'll do half an arch at a time. Gives me complete control of the situation and allows me to suture very effectively and efficiently. Through the rabbit ears again. It's like darning socks. And you certainly can practice this on an orange or a lemon or a grapefruit, whatever you happen to have. And you can get very, very proficient at this. Time in the operatory is very critical to me. I'm a big believer the faster you're in, the faster you're out with the patients, the less postoperative discomfort they will experience. And like anything that we do in dentistry, it does. There is an art to it. Practice makes perfect, and the more of these you do, the easier it will be. So in a very, very short amount of time, we've closed up an area that's a couple inches long. Eliminate postoperative bleeding, and especially in the age of patients that are on blood thinners of some sort. And as we're ending, we use the rabbit ears as my tail and tie the knot. 2, 1, 2, 2 forward, 1 back, 2 forward, and you will get complete closure without worrying at all that this suture is going to come loose. We get closure with attached gingiva 1 week postoperative. Again, epithelium will heal a 0.5 to 1 millimeter a day, and you will get a great result. Again, let's look at, just to review, we have an area, it's very important that we visualize the mucogingival line. You can see that the mucogingival line is pretty high here, which will preclude us having a band of attached gingiva on the facial aspect of our implants. Here I marked it with a Sharpie. And so I'm making my incision. This happens to be what we call an Orban knife. It's a very sharp, precisely angled instrument. And I'm making my incision, my crestal incision, a little bit lingual to the center. Evaluating, it looks like I probably have about a band of 4 millimeters of attached gingiva that I will reposition to the facial aspect of my abutment. I'm going to go around the natural tooth. I'm peeling that tissue away like an envelope. So if you had a number 10 envelope, you can see I'm not making any vertical incisions, which is eliminating incising the mucosa, which is eliminating prostaglandin and histamine release. The lingual tissue, it has remained intact. I did not reflect the lingual tissue whatsoever. And then we go through our surgical implant procedures, small burr, wider burr, wider burr, and placement of our dental implant. And if we're able to torque it to at least 25 Newton centimeters, here I'm going to place my second implant, paralleling it, widening the osteotomy. Our 2 implants are placed. This is called an instrument that's going to create threads. It's called a tap in dense cortical bone. Our implants are precisely placed. Because we're able to torque them, we put taller healing abutments in position. And again, let's slow down a little bit. We're taking our reverse cutting needle from Golden Dent. We're going through the mesial facial aspect of the tissue, that band of attached gingiva, about 4 millimeters, that I move towards the facial aspect of these healing abutments. I'm looping around the healing abutment. I'm not engaging the lingual tissue whatsoever. Going to the distal facial, and again, coming around that healing abutment, a simple periodontal procedure, and tying a knot on my mesial facial, reestablishing the band of attached gingiva that was on the crest to the facial aspect of my implants. Do the same thing with the second implant. 1 week post-op, you can see that epithelium does indeed grow very quickly. Without a lot of discomfort for our patients. 4 months post-op, we clearly have a beautiful band of attached gingiva on the facial aspect. We remove those healing abutments. We have beautiful tissue cuffs, periodontal health, and we will establish a nice clinical result. Here's a more challenging area where we have a split tooth, where we're eliminating the amount of bone and of diseased area in that site. As human bone. And I've done a lot of histology over the years in using this product. It's relatively inexpensive, and Kurt can discuss this with you at the end of the program, but I strongly recommend that you add this as a general dentist in your armamentarium, along with the 3040 3/8 needle, 1/2 inch needle, as one of your grafting products. It's a combination of bioactive particulate in a bovine Achilles tendon matrix. And what's nice about it is it's not only a graft material, but it also eliminates the need for a membrane in your socket sites. So when you're doing tooth extractions and you are doing grafting, either for immediate implant placement or for future implant placement, this is just an ideal material to use. We extract the tooth. We can place the plug firmly into the socket site. We're condensing it firmly but not crushing. We're going to suture over the top of it to eliminate the material from falling out by use. Again, I like to see my patients back in a week to remove the sutures. And in a very short amount of time, we can objectively determine bone turnover radiographically. Physiologically, bone will turn over from the apex towards the crest, and we've gotten some just remarkable results. So here I've taken an osteogen plug, and I'm actually placing it into the dehiscence created in the sinus, placing it firmly, and then I'm going to graft with allograft from Golden Dent. This is an important material, the gold os particulate. It can provide some osteoinductive and osteoconductive surface, which allows for osteoclasts to invade it and osteoblasts to lay down new bone. Whenever we're using an allograft material, which is cadaver bone, you must protect it from invagination of epithelium, which is different than the osteogen itself. Epithelium grows about 10 times faster than bone, and remember I just said that the graft physiologically will integrate from the apex towards the coronal portion. So what I like about the gold os material, again, doctors, is it's very cost effective. It's a very high quality, the highest quality material that we use, and will provide you an outstanding result. So we're repairing that entire defect. And here I'm using the gold os membrane, which is a long-term resorbable membrane. Again, I'm not showing you a lot of different products. There's hundreds of ways of doing what I do every day in my practice, and I'm trying to limit what will make you very, very successful. So we have our two size needles, two sizes, thicknesses of thread. We have our osteogen material, and we have a resorbable membrane. The membrane is passively placed, covering over the grafted site. We're not forcing it, and it has to extend beyond the defect. We use two different materials, an EpiGuide material, which is a synthetic membrane, which works very well, and we also use their pericardium long-term membrane. Here we're repositioning the tissue. Now, when I'm doing a allograft and I'm placing a membrane, one of the biggest mistakes that we may make as practitioners is in our suturing. And it's a suturing webinar here. Most of us would suture from facial to palatal in this situation. And in so doing, we may suture right into the membrane itself. We wouldn't know that because we can't see it. And when the patient comes back to remove the sutures, if your staff's doing that, they may remove the sutures, and it may also remove the membrane. The membrane must remain intact for at least 6 weeks. The membrane must be maintained over our allograft for at least 6 weeks. So I'm using a long-term membrane, but it must be maintained for at least 6 weeks, or the entire case may become unpredictable. So for those of you who have gone through procedures and done grafting and placed the membrane and come back and found that you didn't have bone, it may be a mistake in your placement of the membrane and your suturing. So when I have a membrane, I kind of change my protocol. And here you see I'm going from crest to facial. I'm reversing the needle and going from crest to palatal. And I'm simply doing an interrupted suture or a mattress suture. But again, when I'm using my reverse cutting needle, going from crest to facial, and then turning that needle around, going from crest to palatal, I'm sliding over the top of the membrane. You can see our graft, immediately following graft, you see that we have some radiolucency, radioopacity in that huge defect. 1 week post-operative, we remove the sutures, and I don't expect complete closure. But again, I congratulate the patient, it's nice healing, and epithelium will continue to grow over this site, 0.5 millimeter to 1 millimeter a day. So in another 3 or 4 days, the patient won't even know that we did anything. 4 months post-operative, we now have a site that we can objectively determine for placement of dental implants in the site. We are going to be very conscious from this point on about the mucogingival line. We have a little defect there. So again, I'm making my, my incision over the crest to demonstrate to you the conversion of that osteogen graft and allograft with a membrane, that we do have viable bone in that site in preparation for our dental implant. And again, we go through the surgical site of initial pilot burr, widening the burr, and eventually placing our dental implants predictably, allowing those implants to integrate over time, and we get a good ideal situation. We can do reclose the area. Postoperative CBCT shows us that we have great stability of our dental implant. And again, suture the site, 2 loops forward, 1 loop back. You're only pulling on one end, two loops forward, and tying your knot. And if you're going to do a mattress, come from facial to lingual, go through the rabbit ears, pull through the rabbit ears, and continue that process until the very end, where you have your tail, your rabbit ear becomes your tail, 2 forward, 1 back, 2 forward, and we get primary closure quite remarkably, quite effectively, and easily. So some of you have seen this slide before. I'm in the suburbs of Detroit, and these are some of the patients that we see pretty regularly. You wonder why anybody could walk around like this, but there are reasons. Fear of the dentist, financial ramifications, maybe taking care of their family first. But I strongly believe that there's a huge potential in your practice to learn how to do extractions that are a positive reflection of you and positive for your patients. When we're removing teeth, we know that the bone is going to shrink up and in the upper jaw, down and in the lower jaw. We know that the sinus floor is going to collapse. So grafting is a very important part of what we do every day in our practice. You have to make it cost effective for your patients. Obviously, if we're going to graft, we have to suture correctly to allow for proper healing. We have to protect any allograft from invagination of epithelium. So we have to protect not only the graft, but the membrane itself. And if we're going to place implants, we have to understand the importance of attached gingiva and the facial aspect. This is my go-to extraction technique that Kurt can discuss with you when we're finished, the physics forceps. It's a series of 4 instruments. I can honestly tell you, I would not practice without these instruments. I use them every single day in my practice when we're extracting teeth. It consists of 4 instruments: an upper right, upper anterior, upper left, and a lower universal. It consists of 2 components, a beak and a bumper. The beak is a shovel-shaped edge which will engage the lingual or palatal aspect of a tooth 1 to 3 millimeters subgingival. It is the working end of the instrument. The bumper, here we have a little silicone covering for it, is not the working end of the instrument. It is simply used as a center of rotation. So I will position this bumper as high up or as down low into the vestibule as possible. It simulates a fulcrum, which allows the beak to do its work. We will never squeeze this instrument. Rather, we will simply create tension on the palatal or lingual aspect of the beak by simple rotation of our wrist. That tension will result in a physiologic reaction of the body, which will release an enzyme, which will break down the periodontal ligament. The periodontal ligament is what's holding that tooth in place. It will allow us to luxate that tooth up and out of the socket following that arc of rotation. So here you can see I've engaged the beak, the working end of the instrument, 1 to 3 millimeters subgingival. The bumper, the center of rotation or the fulcrum point, is placed as high up the vestibule. And without squeezing the instrument, I'm simply rotating my hand towards the corner of the eye. In a matter of minutes, that tooth will luxate. I'm then taking what we call a tooth delivery or a bird beak forceps, and I'm removing the tooth atraumatically. Grafting at the time of extraction will help minimize bone loss, will obviously help support the soft tissue, can prevent periodontal pathology, that loss of attached gingiva, and it could provide an adequate site for implants predictably, routinely in 3 to 4 months. Without grafting, we can get soft tissue infiltration. I said that epithelium grows 10 times faster than bone. We will lose height and width, and the literature will say in a 3-year period, we can get up to 30 to 60% bone loss, which may prohibit future implant placement without more invasive surgical procedures. So again, here's another situation. We have a tooth that's deemed non-restorable. I will simply make sure that we have profound anesthesia by taking a periotome. Again, this is from Golden Dent. I think they have an outstanding grafting kit that's relatively inexpensive that you may want to consider. I think if you're going to do this work, you have to have the right tools. I'm just making sure I have profound anesthetic. I'm placing my beak 1 to 3 millimeters subgingival. The bumper or the fulcrum is placed as high up the vestibule as possible, and I'm simply rotating my wrist. In a matter of seconds, that tooth is going to pop up and out of the socket. I will then take a tooth delivery instrument and remove this tooth in total. And you can see the divergence of these roots. And I think this is a real time-saving technique in your practice. Many of you would probably remove the crown and then section those roots and remove them separately. I've cleaned out the site. We curette. And here I've taken my Osteogen plug and I've cut it the size of that root. And I'm simply going to use this material, which fulfills 2 primary purposes. It serves as a graft material and as a membrane. It restricts migration of the connective tissue through a physical and chemical barrier. The physical barrier is created when you compress the plug down into the socket, and this compression gives the epithelium a choice. It can go through, fight through the graft, or go over the top, and it's always going to follow the path of least resistance. So it's a wonderful, time-saving, relatively inexpensive way of maintaining bone in your extraction sites. So here I'm placing the material, packing it firmly, and again, my suturing technique is very consistent. Crest to facial, turn the needle around, crest to palatal, just a simple interrupted that we've demonstrated, and again, crest to facial, crest to palatal, tying my knot, and again, doing a couple more interrupted sutures to maintain that graft material. Give it a good squeeze to eliminate any excessive bleeding. Our immediate post-operative radiograph illustrates that the material has some opacity to it. In 4 months, however, we start getting good bone. And I just want to demonstrate this, Lauren. I'm going to finish up with this case right on the hour. I'm going to make my incision at the crest so that I can demonstrate to you, listening, that we absolutely have bone formation in that area. I will do a lot of histology, and here I've taken a core sample, and without going into too much detail with histology, anything that you see that is magenta in color, the pink, the bright pink, is bone. The purplish color is our graft material that is still integrating. It'll take about a year for bone to mature completely. And as I said, we're going to get integration from the starting at the apex towards the crest. So I feel very, very comfortable positioning my implant at this juncture. Here I'm using osteotomes without getting too much into detail about the implant techniques. I'm simply condensing the hard tissue, replacing again my gold os membrane into that socket site to help lift the sinus floor. That's going to become my new floor. Taking an Osteogen plug and condensing it, and then threading my implant directly into that site. And in a grafted site, a hugely grafted site, we're able to torque that implant to 40 Newton centimeters. You can see that the implant is specifically, precisely at the crest, and my suturing technique is very, very specific. Crest to facial, I'm always evaluating the band of attached gingiva, then reversing the needle from crest to palatal, and suturing. I do not care about primary closure because I know epithelium is going to grow a 0.5 millimeter to 1 millimeter a day, and we will allow it to heal. The implant will allow it to integrate, and we will finish. Again, a very, very damaged tooth. We're simply going to remove the tooth. And here's the Goldas grafting kit that we created. I strongly recommend that if you're going to do this work, you have proper tools. And this is a kit that we designed that I think will be very helpful in your practice. The Goldas armamentarium consists of many, many fine instruments that Kurt can describe in great detail. Very high quality and very cost effective. So here we're going to remove the tooth, and this is a Goldas cow horn, which is a little bit different than your conventional cow horn, but I'll use the same clinical technique. What I'm going to do is create tension, and I'll simply rotate this cow horn towards the palatal first. I will physically count to 10. I will rotate towards the facial, and again count to 10, breaking down the periodontal ligament, and I'm able to remove these teeth in total. I'm evaluating the socket site, reflecting the area, using a sharp curette to remove the heavy granulation tissue that's in that site. I'm going to incise the area, reflect, exposing the defect, and I'll go back to my Osteogen plug that you can purchase through Golden Dent. I will place it firmly into the site and go through my suturing protocol from crest to facial, crest to palatal. 1 week post-op, we do not have complete closure. However, in 3 months, we will have a site ready for dental implant placement. And again, to illustrate that, I'm going to incise and show you the viable bone that was created with our grafting procedures. Doing our histology, you can see the magenta is good bone formation with better formation at the crest. We place our implant, we place a healing abutment, and again, we're evaluating the band of attached gingiva. We make sure that we have that band on the facial aspect. We allow it to heal, and we are able to finalize the case. Lauren, I'm going to stop here because we're on the hour, because I know we probably have some questions. We covered a lot of area in a very short amount of time. It seemed like 5 minutes for me. So if you have questions, let's go ahead and answer them.
Well, actually, first, what I want to do is turn it over to Kurt. You'd mentioned his name a couple of times, and I had mentioned at the beginning that we really can't do this without sponsorship and without the support of Golden Dent. They're the ones that brought Dr. Kosinski in. They're the ones that are going to handle all the CE, the recording going out. And I should mention that again, for those of you who may have shown up a little bit late. This webinar was recorded. The recording will go out usually within a couple of days. The CE, there's nothing you need to do. As long as you're here for the bulk of the webinar, you'll be sent the CE. No quiz, no registration, nothing like that. So, but I'm going to turn it over to Kurt for a few minutes to talk about some of their specials, and then we'll go back to Tim to hit the Q&A.
All right, Lauren, I appreciate it. My name is Kurt Lawler. I'm here with Golden Dent, also based here in Detroit, like Dr. Kosinski. We're a, like I said, a Detroit-based company that we've always focused on simple, predictable, and unconventional dental products. That all started for us with the physics forceps. So if you're a regular joiner of our webinars, I appreciate your time again this evening. And if you're new, I hope you enjoyed the content. And I'm just going to go over just a couple of the products here that were shown this evening, and then we'll get to the questions from the webinar this evening. So like most webinars, we always provide a promotional offer. We do this just, I guess, as a thank you for joining the webinar this evening and investing your time with us. We hope you enjoyed the content, and then if there was anything that was interesting, we also want to provide the opportunity to save a little bit on the products. So golden-dent.com is our company website. And the promotional offer that we're going to provide this evening is a 15% off coupon code. And the code is, now that I'm looking at this, I guess I should have clarified this, but it's 15, and then it's 15 off. So it's 15 and then the letter OFF. So hopefully people don't get that confused with the 150, but it's 15 off. We do these promotions quickly. We just do a 24-hour deals from these webinars. And so this promotion's good through December 8th, tomorrow, end of the day. So one thing that we've had good success with here at Golden Dent, even during COVID and the pandemic and some supply issues that people have been having, is we've had good success. So our regenerative materials are in stock. We haven't changed any of our pricing in a couple of years on our regenerative materials and our sutures and our membranes. And so it's something to take into consideration if you are having some trouble with some suppliers now with allograft or waiting too long to get your products. We do have everything in stock here at Golden Dent. So these are the sutures. I won't spend too much time on this. The PGA one is Dr. Kosinski's preferred choice at the top. We also have black silk and some other sutures, but I know that's not specifically Dr. Kosinski's preference, but we do have those available also here at our company. Our sutures, they're very good. We spend a lot of time making sure clinically that our evaluators like Dr. Kosinski were happy with the suture, and they're priced very well if you do compare them to some other PGA brands. This is our particulate. Again, a lot of companies do have particulate, but like I said, we always have it in stock. We have the allograft. So we have the particulate form, and then we have the DBM putty. We also have the crunch putty, which has cortical chips in it. And if you're using another brand, or if you're not currently using the Goldas allograft brand, we encourage you to try to give us a try. The results have been great from the customers that have been using it for a number of years, and it's a nice quality product at a fair price. Osteogen plugs, this is a very popular product for us. We've had this for quite some time now, and the results are really good. I know our customers are very happy with it. And if you're not using the osteogen plugs in your practice now, it's something I definitely highly suggest taking a look at. The large size, which is the 10 by 20, is definitely the most popular size of the plug, and they come in a 5 or a 10 pack product. So if you are using the osteogen plug, or I guess for really any type of grafting procedure, this is a nice curette that we have. This is going to allow you to remove any granulation tissue from the socket site. And one thing that's very important, which I think we mentioned, is you really have to have proper bleeding with the osteogen plug. If we ever hear that somebody's saying a patient's having discomfort or maybe a dry socket from a type of product like the osteogen plug or the osteogen plug, it's usually because they didn't have proper bleeding. And this is a good solution for that. The membranes, our most popular membrane is going to be the EpiGuide there, the one shown on the left. They're all long-lasting absorbable membranes. And so I would suggest the EpiGuide. It's a big membrane. It's 18 by 30 millimeters, which is a little bit large, but I know you can obviously cut the membrane to shape or to size. But that's the easiest one that we found from a handling perspective. But all three of our membranes are very good, but the EpiGuide is the most popular. The physics forceps. This is kind of what started the product-based business of what we've done here in dentistry over a number of years. This was the standard series set. This came out in 2007 now, which is already some time ago already. And this is going to be the 3 upper instruments that were explained: the upper right, upper left, and upper interior. And then there's one lower universal instrument. So if you've been looking at the physics forceps for a while, or have seen them before, or maybe this is the first time you've seen them this evening, this is definitely our most popular set of instruments. They're the easiest to use and are going to give you the best leverage. We do have one other set of instruments that goes further back into the mouth, a set of 2 instruments, which is our molar series. But I wouldn't suggest jumping right into those. And this set is going to do second molar 2-second molar anyway, so you're pretty much going to be able to cover the full mouth with this standard series set. So this is definitely what I would try first if anybody was looking at these instruments. Do you have to elevate in advance? Not really. I mean, the physics forceps really is a lingual elevator. However, if you want to use an instrument we have called the wedge, or some of our other elevator or luxator type instruments, it obviously will make the procedure even easier and less traumatic. So it's something that you can definitely do prior to using the physics forceps. This is our complete graft kit. We just showed this here a few minutes ago in the presentation, so I won't get into this in too much detail, but this is just a really simple graft kit. It's nice to keep it together. You know where everything is for your graft procedures. The instruments look great, and everything's packed in a simple cassette, and it's ready to go when you're ready to use it. And it's an inexpensive kit to have around in your office. We obviously have a more expensive, more advanced type needle holders. They're actually very good. They're more expensive, obviously, than some of the other ones we have. But the most popular thing with these needle holders or the scissors that I'm showing here on the right is they don't have really any joints. So we call them our snagless needle holders. Doctors really like that because I know it can be annoying when you're doing your suturing procedures to have the suture to snag in a lot of the needle holders that are out there. So if you look where I have some of these circles here, you'll see that the suture will very nicely slide along the hemostat there and never get snagged. Just a couple more slides here before we get into the questions, but this isn't something we showed this evening, but if you are doing grafting procedures, this is a nice degranulation and shaping kit that we put together. You'll see the tissue and degranulation burrs at the top there, and then we have some nice bone shaping burrs that keeps it all together in a nice burr block for your grafting procedures. There's just a couple more slides here I want to mention. So this is not on topic for this evening, but I know if doctors haven't joined one of our webinars in a while, or maybe haven't taken a look at our website recently, we added some new products that we've had really great feedback on. This is our new O-Star wide spectrum curing light. I just wanted to mention it while I had your attention this evening. We've had really good success with this here in the last few months, and it's really inexpensive. You'll see all the benefits on the website, but we even have like a comparison type analysis to like the Valo type light that's $1,600–1,700, or this one's around $400 or $500 range, and we're really finding that the results are very similar or even better. The two endo motors there that we have, this is also something that's been very popular for us, is our new endo line. We have a Pro Taper and a Wave 1 equivalent type file. And this is the Woodpecker AI motor, which has the Dr. Yoshi Teruyuchi improvements. They call it the T mode endo motors. We've had great success with these. They're beyond aesthetically looking very nice. It's a great motor at a fair price. And then in the bottom right there, we have a good obturation system. I just wanted to mention that if you are doing any endo in your practice. So last but not least, I don't think we mentioned this yet. Maybe you've heard that we started our company with extractions, and we've been doing extraction courses for over 10 years here in Detroit under the Amplified Dental training name. So it's a very hands-on type program where you do all of your own extractions and grafting procedures on live patients. So there's no licensing restrictions. If you're not licensed, obviously in the state of Michigan, we do it at a teaching facility, so there's no issues of working on the patients we provide. So you really just need to show up, and we have a course actually coming up. I think it's the next slide. Yeah, this is a really last minute notice. I think it might even be sold out anyways, but we have a course coming up this weekend, and it's a live patient extraction class. So we'll have 65, 85, 100 patients, depending on how many doctors we have. And you actually get to use the physics forceps, actually get to sample and try the osteogen plugs, and obviously are also doing a lot of the suturing procedures on live patients to refine your techniques for your own practice. So it's a really great live patient experience. And then we have some implant training courses here coming up in February, endo course coming up in March, and you can learn all about these on Amplify Dental Dental Training's website, which I have here on the last slide. And again, 15% off. Sorry if I talk too long, and we will get into the Q&A section. And again, if you have any questions, give us a call in the office. We're always happy to hear from you. Thanks for your time this evening, and I'll turn it back to Lauren for the questions.
Okay, Kurt, someone was asking on the website, where would they find the complete graft kit?
I think it's going to be under regenerative instrumentation. It's on the left-hand side. I think it's like the second or third box down. It says regenerative instrumentation, and you should be able to click and find the complete kit there.
Perfect. Okay, thank you. That was one of the questions that we had. Tim, you ready to answer a few questions here?
Absolutely.
The Osteogen plug, does that reduce the incidence of dry sockets?
You know, well, as we know, Lauren, dry socket is a term that refers to when we have a socket, we get a blood clot. And as I mentioned, the program, a site will heal from the apex towards the crest. And if the blood clot is removed through spitting or a straw, that's what we refer to as a dry socket. So the graft itself, I don't think will eliminate dry sockets per se, but if it's maintained in the site, there's no way to get a dry socket. I haven't had a dry socket in my practice for years and years and years. But I think, again, it's very technique sensitive. And you know, Kurt mentioned the courses at the dental school, you know, learning on patients. When we take the tooth out, we want to do it as easily, minimally invasively as possible. We want to curette out all the granulation tissue. Bleeding is important. We can't have integration of bone or bone turnover without bleeding. And suturing is very important because we want to maintain that material in the socket itself. So doing all of those things will eliminate any problems you may be having with dry sockets.
Okay. Yeah, I personally haven't seen dry socket in 19 years, which is around the time I stopped practicing, but okay. Immediate implant placement with barrier. My patient continues to have the barrier come out. I do not have primary closure to encourage keratinized tissue growth. What do I do?
So, you know, again, I think that's a very typical problem, and that I hear a lot on the lecture circuit. It's number one, it's important that the membrane be placed passively, and the membrane must be placed at least 2 millimeters beyond any defect, at least 2 millimeters beyond any defect. Unfortunately, we oftentimes try to force that membrane into position where it will protrude out or will come out before that 6-week period. It must be maintained for at least 6 weeks. Anything short of that, and the entire case becomes unpredictable. So it's more of a technique than anything else, Lauren.
You there, Tim?
I'm here.
Sorry, yeah, we lost we lost it for a second there. What happens when you break a tooth using the physics forceps? Of course, that never happens to you, but if it did, what would you do?
Well, I think it becomes a more conventional technique. I think, taking teeth out is challenging, and I see a lot of root tips left in the jaw because it can be frustrating. So I think the most important thing is that you be able to visualize it. So making a reflection, don't be afraid to be able to see the problem. And if you can see the problem, we can normally fix the problem. And Golden Dent has a lot of they have a bayonet, they have a lot of extraction instruments that are an adjunct to the physics forceps.
Okay. If all else were equal, what would you prefer to do? Would you do immediate implant placement after extraction, or would you implant after the socket's healed for, say, 4 to 6 months?
That's a great question. If there is no sign of infection, no active purulence, then I would prefer to do an extraction, graft, and immediate implant, because obviously the time saving for the patient is incredible. However, if there's any active infection in the area, there's purulence, I will clean the socket, I will graft and allow it to heal first. So if there's active infection, I would not put an implant in an actively infected area.
Sure. Do you ever use short implants? Like mini implants, that type of stuff?
Well, mini implants are small diameter implants, less than 2, FDA said less than 2.9 millimeters in diameter. The shortest implants that we use with the systems that I use is 8 millimeters. That's an engineering design a procedure that the doctor has to decide. Your crown root ratio is very, very important. Your initial stability. There's a lot of things that go into long-term success. I've been doing implants for 36 years, so I pretty much, have seen it all, or most things, and I've learned what works well in my hands and what may not work well long-term.
Okay. Let's say someone has placed an osteogen plug, they go back in 4 to 6 months later, and it's really not solid bone yet. It's kind of soft and immature. Is that atypical, and what might have caused something like that?
The site will always, number one, you have to clean out the socket site. Number two, there has to be good red blood bleeding, not purple blood. You place the graft firmly. You're not crushing it, but it's firm, slightly above the crest. These are just protocol that you cannot miss. You suture over the top, give it a squeeze, and let the epithelium grow over the top. It's going to heal from the apex towards the crest. So depending on how big the defect was, you're going to get more maturity in 3 to 4 months at the apex than towards the crest. So you may not get complete maturity at the crest, but you will get better bone integration at the apex. When you're doing our implant, our initial stability comes from the apical 2 millimeters of the implant, and we're going to allow that implant to heal for another 3 or 4 months. So that integration process is going to continue.
Okay. This is probably a question for Kurt. Kurt, do you happen to know off the top of your head, if you're shipping to Canada, do they have duty fees? I'm from Canada originally, so I know about the sales tax and GST and all that stuff. Do you know if people have to pay that, or how is that shipped?
Yeah, we do ship from USA, so to be honest, sometimes yes, sometimes no. It's there's really doesn't seem much.
Decide to open it.
Yeah, it doesn't really seem to be much rhyme or reason. We haven't had too many problems with that issue, but we don't charge any tax obviously on our side, and then we have pretty minimal shipping fee on our side. But then whether there's duties or taxes imposed in Canada, it can happen, but I think we've minimize that as much as we can on our side, but that's something that we can't control always.
Right. Does the EpiGuide membrane require primary closure for sustainability or preventing soft tissue migration?
No, the only no, you don't. In today's environment, our membranes are such high quality that we don't need primary closure. As long as that membrane will remain intact for 6 weeks, the membranes are such high quality today that no, you don't need primary closure.
Okay. This might be the longest question we've had, but this is from Dr. Ingram, who enjoyed meeting you at the AGD governance meeting in Chicago and at the presidential party. He is using bicon implants. As far as the technique of moving lingual or palatal attached gingiva towards the labeler buccal, at uncovering, place a bicon temporary abutment and use your technique, but there's no undercut on the bicon temporary abutments. So can you create a groove on the lingual palatal of these temporary abutments to use your suturing technique?
I think, it doesn't matter if there's an undercut there. It's just, you want one that's tall enough, and you're tying that knot pretty firmly. So, even if it's a circular abutment, that shouldn't be an issue.
Okay. I guess this is probably a depends question. How much graft do you need to place in the socket?
You place it firmly from the apex to slightly above the crest.
And however much that is.
Yep.
How long do you let the extraction site heal before putting the implant in after the use of osteogen?
You can because you'll see it objectively on a radiograph, and it depends how big the defect was, but you can see more radial opacity over time. But you'll see it more at the apex, less at the crest. And again, when you place your implant, you're going to obliterate that material anyways and get your stability at the apical 2 millimeters. So it really depends on how big the defect was. I would say within 3 or 4 months, pretty predictably, I can go back and place an implant, but never more than 6 months.
Okay. When I do connective tissue grafting, the sutures are broken after 1 week. I feel that I released the tunnel enough, but I think the swelling may be breaking the sling suture. Any tips?
Depends what suture you're using. You know, the Vicryl, the PGA sutures are intended to last about 28 days. Obviously, silk won't disappear, but you know, some of our gut or chromic gut sutures are going to resorb much quicker.
Okay. With the implants, have you ever tried, say, a 6x6 or 5x7.5?
With what? Say that again, Lauren.
With implants, have you ever tried, say, something that was a 6x6 or a 5x7.5?
I know like the Hans system has a 7 millimeter diameter implant that I've never used. So usually no wider than a 5, and the shortest one is an 8. You know, I'd rather build bone and have a proper crown root ratio. I don't think long term putting in a 6 millimeter implant on a 12 millimeter tall underneath a 12 millimeter tall crown is going to work engineering wise.
Sure. Yep. How much graft do you need to place in the socket above a plug?
How much? I'm not sure I understand that question.
Yeah, because the graft would go below the plug, wouldn't it?
Yeah, exactly.
Right.
You know, you
Okay.
can add as much material as you need. What's nice about the osteogen is if you get them from Golden Dent, it's like $40 a plug. So it's not it's not, you're not investing a lot in material costs, and time is very, very fast because it's so easy to use. And you can use as many as you need. And there's different sizes. There's a thin, a large, and an extra large. So there's different sizes of materials. That should be discussed with Kurt when you're ordering.
Okay. What's your decision-making process when you're deciding between, say, traditional bone particulate and a membrane instead of the osteogen plug?
If all the walls are intact, if you have a complete socket, I call that a 4-wall defect, all 4 walls are intact, my go-to is the osteogen plug because it's fast, easy, and I know it's going to work. If there's a significant facial defect, I will inadvertently always use an allograft and a membrane to grow a facial wall.
Okay. Well, it's actually a comment, not a question. But I think this is actually a great idea. One day you should do a webinar on how you treat implantitis. Let's bring in all your failures and why it happened, and
failures, Lauren. I'm not following you. Failures. I'm not.
Well, not you. I mean, talk to some of your colleagues.
I'm
I
just
mean,
kidding.
yeah.
You know that's a topic that treating the ailing failing implant is a topic, and you know this is a topic that comes and goes every 10 years, and it's very hard to treat failing ailing implants. It's a very unpredictable method, and in today's environment, what I tell my doctors is, if there's a serious problem, you're better off just taking the implant out, letting it heal, and replacing it. You know, the cost of the implant has come down. The procedures are become fairly routine for us. So, you know, but yes, that is an interesting topic, but it's a very, very challenging one to have routine, predictable results.
Yeah. Well, timing's perfect. We're done with questions, and we're at the bottom of the hour anyway. So, anything you'd like to say before we wrap it up for the evening?
We're getting pretty good at this, Lauren.
I know.
All right, and I always say, and I know you're under the weather here, and I truly appreciate all your efforts in educating the dentists out there. You know, I truly enjoy your time and giving back a little bit of my experience. I mean, we had a big group today, and I truly appreciate it. I appreciate you and Kurt. Thank you.
Thank you. Well, actually, we have time for one more question. So one question just came in. If someone's been using the Osteogen plug, but occasionally it turns to like, they're saying it's described like mush when there's more than adequate blood flow. Any thoughts on a better protocol to avoid this?
Squeeze, squeeze, squeeze. You put pressure on it like you would a socket site. Like take a gauze and have them bite on it for a while, and it'll squeeze that extra blood out of the graft material, and that will eliminate that mush area. That's a great question.
Well, I want to thank you as always, Tim. I have the pleasure of doing webinars with you on a regular basis. It's been a few years now. I can say with complete confidence that we never see the same stuff over and over. I'm sure many of you know that there's speakers out there that they regurgitate their stuff, and some of them probably still have their PowerPoints on floppy disks. But we don't get that with Tim. We get high quality content. And the reason we do is that we've got Golden Dent to sponsor it, to bring Tim in, to handle the recording, which will go out in a day or two, to handle the CE certificates, which usually take about a week or so. And to top it all off, they make a really great offer of 15 off. They have an excellent, although none of our clients have used it, money back policy. They have fantastic set of everything they talked about this evening is really good. Our clients are clients of theirs. No one's ever, that I'm aware of, has ever returned anything, but they have high praise for the company, for their products, for the support and service. And of course, as Kurt had mentioned, all the educational opportunities you have as well. So we do these webinars on a regular basis. All of you who are here this evening will be invited to future webinars. We know that your time is valuable, so we thank you for joining us this evening. As I said, keep an eye out for those CE certificates in about a week or two in your inbox. As always, feel free to reach out to me if you have any questions. And thank you all. We look forward to seeing everyone on future webinars. Good night, everyone.
Happy holidays, everybody.
Yeah, same.